We're going to talk about geriatric patients, and we're going to talk about patients with special challenges. So, geriatric patients will be first. That's chapter 45 in your book, and then we'll be talking about the special challenge patients, which will be 46. So, um, with geriatric patients, by definition, what makes a patient a geriatric patient?
Somebody over 65 years of age.
Okay. If they're 65, if they're over 65, then then they are for us a geriatric patient. Um, Anybody know the average life expectancy right now of people?
Isn't it 76?
That's close.
What, 78.3 or is it 73.8?
It's 78. The book uses a number of 78.8. So almost to 79. So 78, 78-ish years old is the average life expectancy that's going on right now. So obviously people are living longer than that, a lot longer than that. We get some people in their 80s, 90s. We've got people breaking 100. Um, so people are living longer, but on average, we're looking at about 78 years old for most people. So with that in mind, we're talking about over 65, and then looking at an average of about 78, 79-ish. So, 13, 14 years of being in this category for an average. But let's look at the things that are going to be happening and changing in these folks. Um, from an assessment standpoint, when we start assessing geriatric patients, what are some things to be taken into consideration, or things that we may have to do differently than our normal adult assessment?
Kind of have to move at their speed.
Okay, so these people, as they get older, everything starts to either shut down or slow down. So they're let's remember that their hearing is probably not as well as it used to be. Their vision is probably not as good as it was. Obviously, their physical ability to move is a lot slower. So we are normally in a role of quick and fast. We like to get things done. We like to get it done quickly. So with these folks, we may need to take a slower pace, a slower speed, to explain things to them, to get information out of them, to help them along. So it may be important for us to slow down a bit. What else?
They probably have a longer medical history than some patients might have.
Okay. So a more in-depth laundry list of problems, and in a lot of cases, um, they may not have the mental capacity to remember and to tell you what they all are. So it may be a challenge for us to get these this information out of them, or it may be a challenge to get the accurate information out of them, because they may tell you something, and what you're seeing and hearing, and it may not add up. So the information you get may not be accurate, and you may have to ask things differently, or in a different way. These older people may not understand medical terminology, so using those big, impressive medical words may not work either, because they
Don't have
won't
to
know
worry
what you're
about that with
talking.
me.
What's that?
They don't have to worry about that with me.
Yeah, but that things like words like hypertension, they may not know what you're talking about. So if you ask them, do they have hypertension, they may say no, or I don't know, because they don't know what that is. But they may know high blood pressure. So you may have to use some different terminology with these folks. Medication wise, most of them don't know what they're taking. Some of them do, but a lot of them probably won't know what meds they're taking, what they're for. In some cases, I know you guys have been there, where they just hand you a grocery bag that's full of medicine bottles, and you have to filter through them. So it's very rare. I have seen a few patients that are organized enough that they have a nice sheet typed out with all the medications and dosages and what the medical history is, but that is very rare. You don't get that very much. It's usually they just either don't know, or there's a stack of medicine bottles on the counter, or they just hand you the shopping bag, right?
Yeah, you're lucky if they're in the bag.
uh, so what other considerations for these folks when we're assessing?
You
You
gotta
got
keep them
the
warm.
What's that?
You gotta keep them warm.
Warm? All
You
right.
get old, get cold,
Yeah, why is that?
because their the thermoregulatory system is not working properly.
Okay, so these systems are slowing down and shutting down. Circulatory system not doing as well as it was. Um, their temperature regulating not as well as it was. So in a lot of cases, these people are cold for those reasons. That's why when you walk in their house in the summer, they have the heat on, and they're perfectly fine, and you're about to die. So remember that when you throw them in the back of the ambulance in July, and you got the AC pumping, and those people are shivering because they're freezing. Make sure you're putting blankets on them and that sort of thing, or turning the air conditioning down or off. Any more considerations for these folks during your assessment?
Can be hard
Yes.
to stick them.
What's that?
Can be hard to stick them.
Okay. So IVs, think about these folks as they get older. We hear about this thin skin, this paper thin skin. And so in a lot of cases, be careful with them. They get skin tears pretty easy in some cases. So watch out for that. Poor circulation may mean that it's harder to find veins. Those veins may roll or wiggle around. So you're going to have to put some tension on it to keep them in place while you're trying to get your IV access. So keep all those things in mind.
It's good to get a good baseline on their mental status from, hopefully, if they got any family on scene, because if they're confused, it could be just that they're older and have some early onset dementia, but confusion is also the first sign of a lot of disease processes in geriatric patients.
Yeah, exactly. So we need to know if they are getting into these dementia, Alzheimer's states, if they're getting into this confusion thing. So the best place for us to look is with family, if there's any available. If there's not, we're just going to have to go with whatever we can determine. But with with family around it, it would be a lot easier for us to figure out what their normal is to see if there's any changes. Any more things to consider? So what problems do we typically see with the geriatric patients?
Falls.
Falls. Probably the number one trauma to deal with these folks is falls. What injuries result?
Broke my hip.
Yeah. Hip fractures are a big one. So they get those different skin tear type issues and things like that. But for the most part, from the trauma side, falls is probably the biggest issue. And then hip fractures is going to be the worst injury coming out of that. Anybody have another trauma problem with geriatrics?
I've had, I won't say a lot, but a few car crashes caused by elderly. Because I don't know if they're slow to react or I don't know what goes on, but they were the cause of it, and they were pretty nasty.
Right. So their mental status and mental activity is a little slower in most cases. Their reflexes slow down, so they need a lot more time to process information and react to it. So that's the issue there. And in the driving world, all of our speeds are increasing out there and things like that. So the reaction times are being decreased dramatically. So that is an issue there. Another problem that we see deals with cooking. These folks that are, they're old, but they're still cooking at home, and a lot of times they get distracted or forget that they're cooking. They walk away and then completely forget it, and the next thing you know, they've started a kitchen fire. So in some cases, this is a fatal event. In other cases, though, they may end up with burns. So watch out for burns with these folks in their elderly state, especially if they're still living at home. They also have a decreased sensation. The neuro system is not working quite right, so those nerve endings are not as active, and they may not have the sensation that they used to have. So hot water doesn't feel hot to them anymore. So they have the potential for burns there as well. So you could see an increase with these people if they're still at home, an increase in falls, an increase in burns, an increase in like unsafe activities in the house, like cooking fires, things like that. So watch out for those.
It don't really matter if they're still at home either.
So they're going to fall wherever they are. The bad part is for the ones that are still smoking. If they are smoking, that they're at risk for fires there as well. A lot of them will, fall asleep with a lit cigarette or something like that, and it's a potential for bad times. All right. So common health problems with these geriatrics.
Cardio related, respiratory related,
Okay.
osteoporosis, arthritis,
Get a lot of UTIs.
A lot of UTIs, especially in the females. What else?
For the cardio, specifically CHF.
CHF. Those
A lot of
valves.
diabetic.
Those valves are wearing out, right?
Yeah, a lot of diabetic related problems too, because if a patient gets old enough, they ain't got nobody at home with them. They kind of forget how to use their insulin, stuff like that.
Right. They don't take care of themselves as well. They don't eat as well. They don't. You start to see changes in these folks. You'll see activity changes as it becomes more difficult for them to move around. You will see less hygiene. They're not taking showers as often. They're not doing laundry. They're not brushing their teeth. Those types of things. All of those activities become a undaunting task, and so they stop doing them. And eventually, they'll even stop getting up to go to the bathroom and things like that. So that's when it gets really bad, and probably when they're on their way out of living on their own. What other health problems do we see with these folks?
Cancer.
Cancer?
Yeah, you see some strokes too.
Strokes?
Basically everything.
Yeah. All of their body systems are affected here with just because of age. It's basically like a wear and tear type of thing. Their bodies had a lot of wear and tear, so each system in the body is wearing down and breaking, and you could have issues with all of them. So renal
especially
system,
around here, get a lot of dialysis patients too.
yeah. There is an incredible amount of dialysis going on around here. So the renal systems are going, cardiovascular systems, respiratory systems, and on and on and on from there. So, but those are the major ones, and those are the ones that are probably going to take you down. They'll develop chronic illnesses like cancer and breathing problems, that sort of thing. What cardio heart rhythm are they most likely to develop in the elderly ages?
AFib.
AFib and VFib.
AFib. Yeah, VFib is going to kill them, but AFib is something that they will become more susceptible to. So watch out for that. When you hook these folks up to your machines and get a look at them, you may see some irregular rhythms. AFib being the most prominent. Sometimes they know it, sometimes they don't. Sometimes they've already been diagnosed with it. They may have medication for it, but other times they may not even know it. And if you talk to them about it, it probably won't even register with them. They won't understand. So be careful with that. Again, so when you're assessing these folks, slow down, take your time, use some plain English or some words that they can understand. Don't try to impress them with your fancy medical terminology, because it won't go far. They won't get it, and they probably won't be impressed anyway. But take your time. Look at the surroundings when you're dealing with these folks. See how they're living, especially if they're still at home. We know if they're in a facility, they're probably not getting adequate care because all of these facilities around here suck. So if they're still at home, they you can get some telltale signs of how well they're doing based on what the place looks like, how they look, how they're presenting, that sort of thing. Do they have help at home or not? Are they still on their own? That kind of thing. You guys see a lot of elderly overdoses?
Yeah,
Not
occasionally.
really.
Okay, occasionally you might. What are the circumstances behind these overdoses?
Dr. D'Annunzio ups their medication, tells them not to take the other one, or does not tell them not to take the other one.
Okay, so a change of medication,
Or they
and
accidentally double dosed themselves because they forgot they already took it earlier that day.
yeah, that's typically the worst thing is they forget, and then they double up, or if they have daytime, nighttime meds, they forget one or the other and double up.
Or the
So,
nursing home gives them something that's not even on their med list.
yep, told you those facilities suck.
Yeah.
So,
We had a lady the other day that the call came out as a stroke, and Narcan cured her stroke, but she didn't have anything on her med list that Narcan should have worked on. So somebody gave her something they weren't supposed to.
there you go. She got the good brownies. So typically the geriatric overdoses are usually accidental. It's because of their confusion. It's because of their forgetfulness, their difficulty to remember things. And so that's what will happen. They will forget that they have taken their meds, and then they'll double up on them, or they'll miss a dose, but then they take 2 doses at the same time. So that is the reason why those pill containers for the days of the weeks and the morning and night thing were developed, to help with the remembering. So if you fill them up, then you can see whether you've taken your meds or not, as opposed to just having the bottles on the counter and trying to remember, did I take my medicine this morning? So that's the difficult part about it, is trying to remember. So in most cases, if you see those types of problems, some of these problems that you go to, if they have like a really low heart rate, when you get to this patient, look at their medications and see what type of meds they're taking, and then suspect that maybe they accidentally overdosed themselves because they doubled up or something. If they do that with beta blockers, then they could be showing you like a really bradycardic heart rate, and that could be the reason why, is because they've taken a couple doses of beta blockers accidentally or something. So watch out for those things. What about intentional overdoses or suicide in geriatrics? Reasons for those?
They're more predisposed for depression and stuff because their health's declining. Sometimes they're really lonely.
Yeah. Depression is a big deal in the geriatrics. They're not able to do the things they used to do. They're lonely. People don't stop by and see them anymore. They can't get out and socialize. They're becoming physically limited. They don't walk or get around as well.
They feel useless and they feel like a burden.
Right? They don't want to be dependent upon other people to take care of them.
Good God, I don't want to get old.
No kidding, it's depressing, isn't it? One more reason for geriatric suicides or purposeful overdoses.
They're not as financially stable.
Yeah, that's true. They may not be as financially stable as they used to be, or they may have financial issues.
I've seen them get real
They're
depressed when
tired of being
their
sick.
spouse dies.
Okay. Depression from spouses dying. Typically those older couples that have been married for 40, 50, 60 years, Usually if when one spouse dies, the other one is quickly behind them. I've noticed that they don't usually last too long.
Yep.
One more. Give me the good reason.
They're tired of being sick and they just want to be done with it.
Okay, that's close. Usually, you may see this when they get like a terminal diagnosis.
Mm.
So if they go to the doctor and they give them that good news of, you know, you've got something, this is going to kill you, we can't fix it. If they get terminal cancer or something that's inoperable, there's no fix for it, that sort of thing. They may go ahead and go through with it rather than suffer this thing out until the end. So they'll choose to.
They often
What's
they often
that?
feel that's like the last. They often feel that that's the last decision they get to have control over.
Right. And then they'd rather go out now on their terms than to suffer. And in a lot of cases, they don't
Yeah.
want to be the burden on the family and make the family suffer. So they feel like this is easier. So
I know some dialysis patients feel like that.
yeah. Yep. Because it is, I mean, dialysis is a lifestyle. It's a change and a burden. I
It's
mean,
a full-time job.
it is. You got to do it, you know, a half a day, 3 days a week. You're committed to that stuff, so that is a chore. And then you've got the dietary restrictions that go along with it for the rest of your times and all that stuff. So you will notice that in these areas like here in northeastern North Carolina, a rural poverty-stricken area, you will see certain big clusters of problems. And I think dialysis and renal failure is one of those things in this area. There's just a ton of it.
It's all
But it
barbecue.
what's that?
It's all the barbecue.
Yeah. It you know, it's a cultural thing where we live. Poverty-stricken areas, people are struggling to survive. People are they're eating unhealthy. They're not on a good diet. They don't exercise. They have some hereditary issues. And then with the financial burdens, they have some lifestyle issues. So they try to eat cheaply, which results in like fast food and processed boxes because those are all cheap. And so then you end up with a series of patients that have hypertension, that have diabetes, that have obesity, that have renal issues, and that's what you see in Eastern North Carolina. So,
I literally had a patient tell me one day when I asked her what her medical history was, she said the usual.
there you go, because that is the usual around here. All your patients you can expect to have hypertension, diabetes, obesity, and probably some type of renal issue. And then if you want to throw in, you know, asthma, a lot of them have asthma and
COPD.
COPD, and that's from the smoking. And then they'll have some other kind of cardiac history other than hypertension, and that's because of the diet and exercise issues. So, yep, welcome to Eastern North Carolina. That is it. Talking about financial issues with the elderly, you know, once they get older, they retire, they're on fixed incomes, and a lot of them, and you hear it in this area. I know you guys have heard it more than once that these folks have to make a choice in a lot of cases because they don't have enough money to buy their medications. So, you know, they really don't have enough money to live, the way they should be living. And in some cases, these people may have to choose between the grocery store and the pharmacy. Do I buy food? Do I buy medicine? So, some of these people are not 100% compliant on their medications, but it's because they can't afford them in some cases. Other cases, we know it's people that are abusing their finances and spending it on drugs or alcohol type of thing. But with the elderly, it's more of the fact that they just don't have enough money, and so they need they need some help there with the medications. All right. Any other issues with the geriatrics?
Sometimes they're stubborn and don't want to go to the hospital.
Absolutely. That's the way they were raised. Think about these people. These geriatrics now are like the post World War II baby boomers, and that was the lifestyle back then. You didn't ask for help. You took care of yourself, and a lot of these folks are in that mindset. They will deny pain. They will not ask for help, and by the time EMS is called, these folks are usually in bad shape, because they'll try everything to avoid the doctor. The biggest thing is they don't want to have to pay the bill. In a lot of cases, that's what they're worried about. That's why they don't want to call us, because they know they're going to get a bill. So, in certain cases, when you get these geriatric patients, they are in bad shape because they've waited so long trying to avoid this. When you're doing your assessment, you need to use all of your senses in assessing these folks. Watch them. If you're palpating things for pain, don't just ask them, does it hurt? Because they'll tell you no. Make sure
Look
that
at
you're
their face.
watching them. What's that?
I was saying, look at their face.
Yeah. Watch them, because their facial expression will change, or their body may flinch. But if you ask them, does it hurt? They'll tell you no. So we know they're in denial to some extent, but they're just trying to shake it off. They think they can shake it off and walk it off. And a lot of these people, they're having issues, and I hear this so many times. It's like they have a headache, or they don't feel good, and they go to bed at night thinking they can sleep this off, except the problem is they're having a stroke, and you can't really sleep off a stroke. So when they wake up in the morning, they're a lot worse. But the time frame for our windows are now closed because they went to bed rather than going to the hospital. So yeah, stubborn. You want to hear stubborn? Let's talk about stubborn for a second. I'll give you my patient that I went to one night. He's a home dialysis patient, and he was doing his home dialysis, and the EMS crew, they called. He was having chest pains. They called. The EMS crew got there before me. They ran a 12 lead, and I got there, looked at him, looked at the 12 lead, and I was like, elevation. It's like, this guy's having a heart attack. So I went ahead and got a helicopter called. At the time, we had the local helicopter, so it was real convenient. I called, got them to land. We got the guy loaded into the ambulance. We transported him to the helicopter. The crew got in the ambulance. We did the paperwork. They started assessing him, took all of the stuff, and he absolutely refused to get into the helicopter. Would not go. Tried everything. We talked to him. The helicopter crew talked to him. A lot of people that did the from the fire department that did the landing zone, they knew him. They talked to him. Nobody could talk this guy into getting into the helicopter. So we ended up ground transporting him with the helicopter crew to the local hospital. And as soon as the ER doc saw the 12 lead, he wanted to fly him to a heart center. And I explained to him, because he asked where the helicopter crew went, and I explained to him that the patient wouldn't get in it. So I said he would have never gotten here, but he won't get in it. So he went and talked to the patient. The ER doctor actually made the guy, as the patient, sign AMA paperwork because he wouldn't get into the helicopter, so that the doctor couldn't be sued and held liable. He ended up getting ground transported to a heart center about 8 hours later. So yeah, I mean, he could have been at a heart center and a cath lab in less than an hour from the time we were on scene, and it ended up taking him about eight or 10 hours to get there because of his stupidity and stubbornness to not get in the helicopter. I even tried to get the helicopter crew to knock him out. They wouldn't do it. So I was like, let's just give him a shot and sedate him, and then you can put him in the helicopter. But
Did you tell him what his movie options were? Because a lot of people won't fly unless there's a movie playing.
yeah. Oh, I told him all kinds of things. I was like, get in this helicopter or die. Those are your choices. We talked all
Nobody
kinds of
knows that
things.
movie.
We talked all kinds of things. I mean, the flight crew was two good looking ladies. So I was like, you can take a ride with them. Couldn't even talk him into that. So there was all kinds of things talked, but I mean, he was adamant. He was adamant about two things. One was he wanted us to ground transport him, and he was in Edenton, the Edenton area. So he wanted us to ground transport him to Albemarle because that's where his doctors were. And I told him that was not going to happen. And he was adamant also that he was not getting in the helicopter. And that didn't happen either. So I don't know. I mean, sometimes we can talk people into stuff and sometimes we can't. I couldn't talk that guy into anything, but anyway. Good luck with your car salesman skills on some of these people because you're going to need them. All right. So that is the geriatric chapter. These people are different. In a lot of cases, they're on the downhill slope. Now, don't get me wrong, all geriatrics are not feeble or frail. There are some very spry geriatrics out there that do quite well at 80 or 90 years old. And they are just doing fantastic, living on their own, and their mind is sharp as a tack, and they can do for themselves and get around quite well. So you'll see those people, but a lot of these folks are going to be old. They're going to be slow. They're going to be non-mobile. And remember, once they stop moving, you're going to start getting chronic issues like decubitus ulcers and the fact that they can't move and do for themselves. So the personal hygiene is gone. They're dependent on everybody else to give them baths and do the bathroom thing and all that stuff. So you'll see these changes in them.
And then when they do go to the bathroom, Grandpa Vagels down and passes out. You got to scoop him off the bedside commode.
Yep. Isn't it nice?
Oh yeah.
Or they just lay there and poop their pants, which is even more fun. So as we transition into the patients with special challenges, the chapter 46, you will see that in a lot of cases, these elderly people are in both categories. So the geriatric patients will be those patients with some of these special challenges that we're going to talk about. However, some of these special challenges could be throughout life. So it could be from birth all the way to death, or they could happen sometime during their life, and then they have them for the rest of their time. So patients with special challenges, or the special populations, let's just get a list going of what do you guys think? What are some of these special situations?
Hearing impairment.
Hearing impairment,
Blind,
blind.
special needs,
Well, that's what we're talking about. What kind of special needs?
like I'm trying to be politically correct.
Autism.
Mental
Mentally-
disabilities.
Like
Yeah,
the
mental disabilities. That's what I
Yeah.
was
Okay, mental
looking for.
deficiencies. They're not.
Yeah.
They've got some developmental issues, those type of things.
Speech impediment.
Autism.
Okay, autism, speech problems.
People are dependent on like some sort of device, like people on home oxygen. I don't know, CPAP.
Okay, what other devices? We got a home oxygen, CPAP,
BiPAP.
Catheters.
catheters, BiPAP,
got the life vests.
life vests. Come on, give me the big one.
Ventilator.
Ventilator. That's the big one. Home ventilators. So let's talk about these devices for a second. So we got a lot of people now on CPAP, right, at home. What's the problem with them? Why are they on it?
So most of the time it's sleep apnea.
Yeah,
Yeah.
sleep apnea. A lot of people are being diagnosed with it. They're getting the sleep studies done, so they're wearing the CPAPs at home. Most people are not wearing the CPAP for any other type of treatment, not like a breathing treatment or anything like that. These monitoring systems now are monitoring apnea. So you may get some calls where the monitoring company has called in an alarm for apnea because these devices are now recording, they're transmitting, all of the technology changes. So you may start seeing some of that stuff where like prolonged apnea may trigger an alarm, and it may send them a monitoring signal. So watch out for those types of calls there. So CPAP at home. I don't know how much BiPAP there is at home, but typically BiPAP is in the hospitals. We're not carrying it, and I don't know how many people have it at home. Home ventilators, people that are on the vents at home. I will tell you that all of these devices, if you're responding to a call at a house that they're using them, use the family members that are taking care of them, because I guarantee you they're probably a lot more knowledgeable than most of us are with those devices. So trust what they're telling you. Ask them questions if you're not familiar. Let them explain stuff to you. I'm not opposed to even letting them go with you and help along the way with that equipment. Can you transport ventilator patients?
Yes.
Yes, if they are being transported from home. Okay.
What
Uh,
does FiO2 mean?
That is your,
The book briefly touched on it, and it didn't explain what it was.
it is a, so in your O2 readings, your SpO2 is your saturation that you get on your pulse ox. The FiO2 is a fraction of inspired oxygen. So that's what you're taking in. And it's one of the pressure readings that they set for the ventilator. So you have an amount. You have like a air intake amount. Remember, for adults, the amount of air is about 500 mLs for a normal breath. That's what a BVM, basically like a BVM squeeze, is about 500 mLs. So that's how much air is being put in. And then if they're on oxygen, then the FiO2 is going to be a setting for how much oxygen is introduced into that.
Okay.
So again, these folks that are taking care of those vent patients at home, they're probably going to be fairly knowledgeable with these types of things. So I would use them for their information and their abilities. If you are transporting a vent patient from home and the ventilator malfunctions, what do you do?
You can bag them.
That's right. Take the vent off and just bag them with oxygen for your ride to the hospital. Okay. That's one of the reasons. If you guys, I know some of you do hospital to hospital transports. You're taking folks out of the ER to other facilities, and some of you guys, your agencies don't do that. If you're in an agency that does that, if you're doing vent patients out of the ER, going to a specialty hospital, then in most cases that's going to be a paramedic level ride, and in all cases there has to be an extra person in the back with the patient.
Yep.
And that's the reason for that, is in case the vent malfunctions or there's an issue, they've got extra hands back there to bag the patient.
A lot of our ventilator transports, the medic that takes it has to be propofol trained too.
Yeah, because typically they're going to be sedated, and that's their choice of sedation is
That's the
propofol.
Michael Jackson killer.
There you go. So, but that's usually, propofol is usually what they use to keep them sedated and under. So, propofol trained, and typically they always ask to have you got to have a third person on the crew, because you have to have 2 techs in the back, and that's the reason for that, is if there becomes a ventilator issue, then it's going to tie up one person just to bag them. And if there was only one person in the back, you couldn't do anything else for them. So you can't do you can't do anything with the monitor. You can't do anything with medications. And so that's why they want the extra hands back there. Have you been on those trips, Zach? Have you been the extra person in the back?
Yeah, probably like 2 or 3 times.
Yeah. So in most cases, there's not a lot to do, right? Once everything, things are set up, you just monitor and ride.
Yeah, we hadn't had any issues yet.
Yeah.
Knock on wood.
So as long as the tube stays clear and the vent's working properly and everything's going smooth, it's just sit back and enjoy the ride. But if there were to be issues along the way, if for some reason you hit a big pothole and the tube bounced out, or if something malfunctioned with the vent, then it would be a lot of work coming.
a pretty big possibility coming down Brambleton Avenue to Norfolk General.
Yeah, no kidding, right? So there you go. Home devices. Somebody said something about a vest. There's a couple different vests out there. One is a like a defibrillator type vest that they can wear that will actually shock them. There's another like a vibrating type of vest like cystic fibrosis patients wear that it just sits there and vibrates and shakes their chest and beats them up so that it can loosen all that mucus in the lungs and get things stirred up so they can breathe better. So couple different products out there.
I know the book doesn't talk about it, but LVAD patients.
LVAD patients. The book does talk a little bit about it, but not a lot. There is a. Let me see here. Vascular access devices.
That's about the only thing it talks about is vascular access. It doesn't talk about the actual LVAD.
Yeah, it doesn't talk about the LVAD specifically. So yeah, let's talk about that for a minute. LVAD patient. There are some in this area. So
Yes.
what does that device do?
It pretty much is their heart.
Yeah.
Like their heart is disconnected from their body, and that thing pumps it at a constant pressure. Their heart doesn't beat, and they have no pulse.
That's what's weird about it. LVAD stands for left ventricular assist device. It is a pump, so it actually is supposed to assist the left ventricle in pumping blood out. It is a continuous pump, though. It's not like the heart. The heart is a intermittent pump because it pumps and then it refills and then it pumps, where the LVAD is continuous. So it's continuously pushing blood through your system. So when you feel for a pulse in these patients, you won't feel one. And when you try to take a blood pressure in these patients, good luck. So vital signs are a lot different in your LVAD patients because it's very difficult to get the standard set of vital signs. What else?
Pretty much, you just listen. You just listen for the hum.
Yeah, you can hear it either with or without a stethoscope. You can hear the pump running. Obviously, you know it's working if the patient is alert and awake and oriented, then you know it's working. But as far as coming up with concrete vital sign numbers, you can get respirations fairly easily by looking at them, but pulse and blood pressure are a little more challenging.
I think the LVAD set at one specific pressure though.
Yeah, it maintains a pressure on the system. It's a constant pressure. And if you do get a blood pressure, it's going to be like taking a palpable blood pressure. So it's only going to be a systolic number, which is what that thing is set at. So you won't get the diastolic number. All right. I know Perquimans and Pasquotank both have LVAD patients that live in their area. So be on the lookout for those. A lot of these agencies are getting pretty good at notifying the folks that work there of these special population type patients. So if there's LVAD patients, if there's home ventilator patients, if there's in a lot of cases, if there's seriously, grossly obese patients where you're going to need extra help, those things, Keely, aren't you guys putting a lot of those things in the CAD system so that when 911 comes up, there's markers in there with these notes?
Yes, as soon as you would put in the address, a FMP would pop up and it would tell you whether, law enforcement's needed for some things. If, like, we do have that one LVAD patient in Hertford, that'll pop up.
Right.
All that information will come up and we would relay it to you.
Yeah. So they're getting real good at this.
And I don't know what that Jonathan sent out an email on that one. And I don't know if the patient's still there or not, but we had something in Woodville. It was like if you go to them, then they have to go straight to Virginia.
Right.
I don't think there was no stopping at Albemarle. It was you're clear to go all the way to Virginia with this one.
Yeah, she was a young in her early 20s. She had very bad heart problems. I don't remember the specifics of it though.
Right.
Yeah, I think for Pasquotank in our destination protocol, it states that LVAD patients are supposed to go straight to a heart center.
Okay. So if y'all pick up your LVADs, you're cleared straight to Norfolk.
Yeah, it's like the only time we ever go straight to Norfolk.
Right. Right. All right. So so those things are out there. Let's keep going with this list. All right. We've got hearing, vision, we've got the home devices, lots of those. What else do we have?
Bariatric patients.
Bariatric patients. The book talks about bariatric. Do you know what weight somebody needs to be a bariatric patient?
Isn't it like 450 to almost 500 pounds?
I don't know. I'm just asking.
I'm gonna say I don't think the book actually went into detail about the weight that they need to be at.
I don't either.
I'd be more along the lines of like a body fat percent.
Yeah, it says over 35% body fat. I don't know. You know, we can't take that measurement in the field, I don't think. So, or nobody
If they're
knows
wider
how.
than the stretcher, we've got to make them.
That's the problem. You know, most of our stretchers, the regular stretchers are rated for 700 pounds. The problem is they're not wide enough to hold 700 pounds of people because those people are very wide. I was talking last night to the crowd about bariatric ambulances because they are special ambulances. They have wider boxes on them. They have ramps in the back rather than just pulling the stretcher out and dropping the wheels. There's a ramp system.
Yeah, I never seen the rollback system come out of an ambulance to winch that ass up there.
And typically there's a winch in the front, up at the front of the head of the stretcher, so that they can winch the stretcher up and down with the patient on it, and it'll roll down the ramp. So special ambulances, they cost a ton, and no one in Northeast North Carolina, I was asking, did anybody have one? Somebody alluded to the fact that Bertie had one.
Greenville Fire and Rescue's got one.
Greenville's got one. I think Derek said that Bertie had one. So I don't know for sure. But I guess he said that Pasquotank had called for it and got one from Bertie before. So I don't know if that was EMS or if that was the ambulance service. But I know one of the transport companies had one, but they were like down towards New Bern or something.
Didn't Phyllis used to have one in her fleet?
I don't know. So
if she did, it's property of the government now.
Yeah, no kidding. Because Pasquotank didn't get that. So the problem with bariatric patients are they are very heavy and very large, and in a lot of cases it becomes an issue when they become immobile. So then we have to do all the moving. So it takes a lot of people. We've got those Titan tarps now where we can, it's kind of like moving a whale around, but those things help out a lot. The problem with using a lot of people to move folks is houses are not made to use a lot of people to move folks. So there's not enough room in the hallways and doorways and things like that. So it becomes an issue for us. What's another special category?
Homeless.
How about that? They put homeless people in one of these special categories. So issues dealing with homeless people.
Bad hygiene and definitely not medication compliant.
Absolutely. Those two things are for sure. It's also difficult during the paperwork because they don't want to give you any information. So you'll be lucky if they give you their name and if it's even the correct name. Is there homeless people around here?
Absolutely.
Oh yeah.
Yeah.
Got a slew of them in Pasquotank.
Yeah. So the weather situations play a part in the homeless folks. If you do happen to have to run on these folks, be careful about your personal protection. You don't know what they're carrying on them. You don't know how they're going to react. Again, their hygiene is going to be not good at all. They wear the same clothes for days and weeks. They don't take showers. They're probably not eating well. In most cases, they don't have money. And if they do, they're not spending it on their medications. So
You start hearing from them a lot more when it gets cold.
yeah, you get more runs on them when it's cold because they're trying to go somewhere warm. In some cases, they'll like commit a petty crime so they can get arrested. All right. Who's got another category?
Abused patients.
Abused patients. They put abused patients in the special category. Abuse can occur at any level, any age. So from birth to death, there child abuse. There's elder abuse. There's spousal abuse in the adult ages. So this could go on at any point in time. So be on the lookout for it with any patient, any age group. Look for those signs, those injuries. You'll see various injuries, multiple injuries, and at various healing stages. Those types of things. If it's a broken bone or fractured bone, look at the type of injury that it is. Kind of like a twisting motion, things like that would clue you into it. Patients that have been hit, some kind of blunt force trauma, bruisings, hit in the face or around the eyes. There's all kinds of things there. And typically, if you suspect this, try your best to get the patient alone and see if they're willing to admit to anything or talk to anything, discuss any of those things with you. And again, if you do suspect this, whether it's child abuse or elder abuse or any other, you do have a duty to report it. And who do you report it to?
The receiving physician and RN.
Yes. Make sure that you report this to that receiving doctor at the hospital. So whoever's going to be the doctor taking that patient, talk to them, explain to them your concerns, and then they have an obligation to do some things, investigate some things, and then they can report it further up the chain to law enforcement, social services, those types of places. if this does travel anywhere and get any traction, make sure that your documentation is very detailed and your documentation is very correct. If this turns into like legal issues in court cases, this could end up there. So be careful of those things. You may be testifying in court. Your patient care report may become evidence in court. So make sure all of that documentation is very accurate and detailed.
Most of the time, it gets squashed right there at social services.
Yeah, a lot of times it will, but just in case.
That'll irritate the crap out of you too. After
Yeah.
you go and document all this thing, and social services like, oh well, we're not really going to take what you say, but we're going to take what the caregiver says.
Right. And then they have to wait for a more significant injury to occur before they actually do something about it. All right. Keep going. Lots more special people out there. Everybody's special.
Patients on hospice.
What's that?
Patients on hospice.
Patients on hospice. Oh, isn't this a fun topic? People on hospice is a special category. Hospice is a special category. So typically, if you're on hospice, you're a terminal patient that is at the end of your time, and they are there to help you through until you are done. So what hospice is supposed to do is provide a service to the patient and the family to help them keep the patient comfortable, help manage the patient through their final days. As that turns into reality, we find out it doesn't always work that way. Who's ever gotten called to a hospice patient?
I have.
Yeah.
Yeah.
I have to.
Did you
They
say,
were-
why are you calling me?
Yeah, instead of calling hospice, they called EMS, and the person, we just verified that he was dead. And then hospice came right there with the DNR and said, "Oh yeah, by the way, he's ours."
Yeah. So it's a weird animal, and it doesn't always work out all in the execution of it, the way that it's designed on paper. It's a good system on paper, but it's not executed well. I find the biggest problem with hospice patients is that the family is not educated on hospice as well as they should be. And in some cases, the hospice personnel could use a little education about what EMS is actually for. So in those cases, try to remain calm and do a little education with folks. Sometimes people do call 911. It's family members that call 911 and not the hospice people, and the hospice people don't even realize that it's happened until we show up. So that's a lack of education for the family, because the hospice patient will die, and then somebody will walk out and jump on their cell phone and call 911 to tell us they're dead.
Yeah, every single
Okay.
one that I've gotten, it wasn't never the hospice people calling. It was always a family member. And they're
Yeah.
like, well, I don't know if we should be calling you or hospice. And then they end up ultimately wanting EMS.
Right. And so we have to ride out there and say, yep, they're dead. But yeah. I will tell you that if there's issues with who's gotten called to a hospice patient for a medical reason that they want treatment.
Me.
Okay. Hospice does not, it's kind of like a do not resuscitate order. It does not mean do not treat. It just means do not resuscitate. So we treat people for medical problems, but if they get into a point of cardiac arrest, then that's when we let them go. Hospice is kind of along those same lines. It's not a do not treat order. So if they have some issues, there are some relevant issues that they could be treated for. However, we do realize that they are at the end stages of their life, and so the end is coming. But there's still some situations that we may be called to do some treatments for that. And I know you guys probably are thinking, why in the world are you calling me if they're on hospice? We know they're dying, but they're still, you still may have to do some treatments on these folks. Also be mindful, most of these hospice patients should have a do not resuscitate order, because we know that they're going away, but be mindful of the North Carolina most form. They could have that most form in place of the do not resuscitate order. So with that most form, that's kind of like an a la carte menu. They get to pick and choose what they want, what they don't want. So if you're presented with that form, that's that pinkish purple color form, then make sure you read it and see what they actually, what treatments they do want, what treatments they don't want, so you're not doing something that's not listed on that form. Any other special populations?
Feeding tubes and catheters.
Feeding tubes and catheters. All right, feeding tubes. They go straight into the stomach area. All of their food gets put into a blender and then drawn up into a syringe and pushed in. I have seen people pull those things out, so be careful of that. They'll rip that sucker right out.
That's the most feeding tube calls I go to, is that their G2s come out.
Yeah. So typically that's about the only issue that you see with them, is that they rip them out. So they'll have to go and get it put back in. Catheters, there's some people have catheters like long term, so they'll have the Foley's or the suprapubic catheters put in long term. So watch out for those. Those people are highly susceptible to UTIs and other infections. Make sure if you're transporting those folks that you're mindful and you get all that stuff. Don't leave it hanging on one bed and try to drag them to the other. That's a little painful for them. They'll start screaming as soon as you do that. Also be mindful of the bags, the colostomy bags, the J pouches, those types of things. So a lot of folks have those on them. Be careful of those. You don't want to squeeze them and pop them. Any other special populations?
Shunts.
Who?
Shunts.
Shunts?
Yep.
Okay. Most popular one will be the dialysis shunts. For us, we're not going to be accessing those things for an IV site, but what's the most common problem with them?
They bleed.
Yeah, they bleed. So stopping the bleeding, biggest concern for us. If those patients are at home, by the time you get there, it's probably going to look like a slaughterhouse if that thing's bleeding and they can't control it. So make sure that you get it controlled. the patients and the dialysis centers are quite protective of those things because they are surgically implanted and they're difficult. The locations are limited, and so they try to protect those things as much as possible. But that's really not our problem, especially if they're bleeding. What else?
The one that gets put in your head for CSF.
Yeah, that's typically in babies. Usually doesn't go outside of that category. And most of the time, that's the baby thing. I have never seen that, so not quite familiar with how it looks and is. But it's a drainage port for spinal fluid to keep the pressure off the brain because the body's overproducing.
I don't know if the book has this section, but patients with a language barrier.
Okay, language barriers. That is an issue. I've had some patients that don't speak English, or they say they don't speak English. You know, if you watch TV, you find out the harder you hit them, the better their English is. But we can't do that, so they just say they don't speak English. So if they don't speak English, I don't speak Spanish, then we got an issue. So language barriers, we do have some technology now, so they've got some translators you can get on your phone and put on there, and it'll help. You can say something into it, and it'll translate it for you so they can hear it. I've never tried that, so I don't know how well it works, but
It doesn't work that good.
doesn't work that good. Yeah, that's kind of what I figured.
I had a guy the other day, and I think he understood my English better than he understood my phone in Spanish.
There you go. So they do have some translator capabilities at the hospital with the telemed stuff, so they can get a translator on the video screen that can talk to them and help. That doesn't help us until we get them to the hospital. So
I know our 911 can get translators for us.
yeah, okay. Yeah, if you have translator capability in the form of other responders or law enforcement or something like that, and you know it, it's good. You can call and get them. If you have a phone number, you can call and get a translator on the phone so that they can help you out. Put them on speakerphone and they can do that. But other than that, you know, it's kind of like do the best you can until you can get them to the hospital, and then they can figure out what language translator they need. All right. So as you can see, there's quite a bit of special population patients. Again, our agencies are doing a fairly good job, and within the agency and within the 911 center of knowing about these patients. If the families let us know about these patients with them being at home, then the 911 center will flag it, and the information will get put out to us that those patients are living in the response area. So you can kind of study up on what their issues are and what their treatments need to be, and how you need to manage these patients specifically. So that way you can get the right stuff dispatched to them. If you need extra people, they'll go ahead and send it right away, or that type of thing. Or if you have a special transport destination, you can go ahead and plan for that. Other than that, I mean, dealing with these folks, it may take a little bit of change out of your normal assessment process. Again, with the geriatrics, slow down, take your time. You may have to some people hear better in one ear than the other, so they may tell you go to the left side or the right side and talk to them because they can hear you. So do that. If you're dealing with the special populations, if they're children, if they have some developmental issues or mental deficiencies, that may take a little more explanation, a little slower approach. Things like autism and those types of issues, you could have to do a little more talking and trying to reason with these people, um, because of their reaction to what's going on. So uh, I find it easier to identify blind people over deaf people. So the people that have hearing problems are a little more difficult if you don't know it right away to come across and figure out. Um, they may look at you funny or not answer you, and it's because they can't hear you. Um, so work on that with them, and keep these things in mind. I know we get into our normal routines of expecting everybody to be like us and everybody to be fine and answer your questions and things like that, but there are some special things out there, so those folks won't have those abilities, or some people just can't talk, so they won't be able to talk back to you. They can write things down. They may be able to write, so they have to write answers down on a notepad as opposed to being able to talk to you. So keep those things in mind. Anybody have anything else? Questions, comments, follow-ups?
I'm good.
All right. So we'll do some more with these in the labs this week. The special populations, the geriatric patients. Again, if you were planning to retest your Module 6 exam, if you're doing that in Prequimans Wednesday, that'll be at 5 before the lab starts. So be there at 5, and Caitlin will be there to meet you and do that. And then you'll have your lab at 6.
Is it 3 hour, 4 hour?
I don't know. Let me see. This week's lab is 3 hours. Okay, so 6 to 9 Wednesday night in Prequimans, or 9 to 12 Thursday morning at COA. If you're going to COA on Thursday morning, they've locked all the buildings, so you're going to have to wait for your instructor to let you into the building. So go to the front door, and they will open the door for you.
Okay.
All right.